go on the record. This is 2018 CF 492, People versus Travis Wiley. We are in the middle of a jury trial. We've heard this is the third day of evidence in the case. Heard evidence this morning. The people rested. Defense advised that their witness was delayed, expected to arrive at about 2 o'clock. We're about 5 minutes to 2, 5 minutes until 2 o'clock. Mr. Wiley is present in court with his counsel, Mr. Nelson. People present by Mr. Barnard. Counsel, while we are in this waiting mode for the witness, either of you have any matters you'd like to raise? We'll begin with Mr. Nelson.
No, Your Honor.
Okay. Mr. Barnard.
No, Your Honor.
Mr. Nelson, what is the status of your witness?
Your Honor, I was, right before you came out, I was going to go out and see if she was here.
All right. Why don't you go ahead?
Ready? If you would like, you could just wait here, and then I'll have them send you in. Our witness is here, Your Honor.
Okay. So are you ready to proceed?
Yes.
Okay. Let's have the jury. Okay, the record should reflect that the 12 members of the jury, the 3 alternate jurors, are all present in the courtroom. Ladies and gentlemen, this morning you heard the people have rested their case. So at this time, Mr. Nelson, would the defense like to call a witness?
We would, Your Honor. I would call Dr. Jane Turner.
Step right here. Right over here. Yeah.
You do solemnly swear that the testimony you may give in the cause and opinion before this court shall be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Okay. Come around here. And feel free to adjust that microphone to the right height. And I would ask that you speak into the microphone and try to keep your voice up as best you can.
Yes, sir.
We've had some difficulty with that. Okay, so go ahead, Mr. Nelson.
Thank you, Your Honor. Good afternoon, Doctor.
Good afternoon.
Would you please state your name for the ladies and gentlemen of the jury?
My name is Dr. Jane Turner.
And Dr. Turner, what is it that you do?
I'm a forensic pathologist.
And do you currently have a business?
I do. I have a consulting business where I review cases and provide opinions based upon those reviews. I also perform autopsies for coroners in Missouri and private autopsies.
Okay. How long have you had your business, Virchow Consulting?
I started that, I think it was around 2007 or so that I started the consulting practice. Attorneys started asking me to review cases for them. I was employed by St. Louis University already as a professor and worked as a medical examiner at the city of St. Louis. But I was permitted to start this consulting practice on the side.
Okay. And we'll get to the nature of your other employment here in a minute. Could you inform us of the nature of your education? Do you have a bachelor's degree?
I do,
And where did you obtain that degree?
from St. Louis University.
And could you kind of give us a summary of your education up through your doctoral degree?
I graduated from St. Louis University with a BA in biology. I then enrolled in a PhD program at St. Louis University in physiology, which is the study of how the body works. And I was in the Department of Physiology, which was at the School of Medicine. After beginning that program, I decided to apply to medical school. I was already taking medical school classes with the medical students, even though I was a graduate student. And so I applied and got into medical school at St. Louis University. And I alternated my coursework and my research work for my PhD. So I ended up graduating 1 year with a PhD and then the following year with an MD, but it took several years to get there. And I trained in anatomic and clinical pathology. I started that residency training program at the University of Oklahoma Health Sciences Center, and ultimately moved back to St. Louis in the middle of that training to complete my training at St. John's Mercy Medical Center in Creve Coeur, Missouri.
If I could, Dr. Turner, if I could just back up just a little bit. What year did you obtain your medical degree?
1992.
Okay. Following that and following your, or what year did you obtain your residency?
I started the residency in 1993 or so. I was married to the military when I graduated from medical school, and so we moved around, and I couldn't start a training program, plus I was having babies. So I couldn't start a training program right away, but I did start training about a year or so after. It was 18 months after I graduated.
Okay. And following your residency, did you pursue your education after that?
Yes, well, I did an additional year of training in forensic pathology.
Okay. And through that, and that was your fellowship that
Yes.
you were referring to? Okay. And where was that?
At St. Louis University.
Okay. Let's shift gears a little bit and move toward the nature of your employment. Starting with the time that you were in medical school, would you kind of give us a summary of your employment from that time up through the present?
In medical school, I was not employed. Medical school is very arduous. When I was taking care of patients, I was working like 60 hours a week. So there was no pay and a lot of education and training. Then when I entered residency training program, there is payment associated with residency training. So I was paid by the University of Oklahoma Health Sciences Center when I was there, and then by St. John's Mercy Medical Center when I was a resident there. Then with my fellowship, I was paid by St. Louis University at a fellow's salary.
Okay. Following your fellowship, where were you employed?
Primarily at the City of St. Louis Medical Examiner's Office as an employee of St. Louis University. So after I completed my training, I was hired as an assistant professor of pathology.
Okay. Your work in the medical examiner's office, what did that entail?
That involved performing medical legal autopsies in order to determine the cause and manner of death. It also involved testifying in cases, depending on the findings in my cases. It also involved teaching medical students and residents.
And how long did you work in the medical examiner's office?
I was there 18 years.
Can you briefly summarize for us your experience in the role of teaching?
I mentioned that I was teaching medical students and residents when I was an assistant professor. That evolved over time as I gained more experience and background in teaching. And at one point early in my career, the forensic pathology training program that we had in the office was headed up by someone else, and the accrediting agency suspended the accreditation because the program didn't provide enough teaching and education. So I offered to take over the program. I already had developed a curriculum for the medical students and residents, so it was a natural for me to take up the forensic pathology fellows to teach and train them as well. So I did that, and we got, I was able to get our program accredited, fully accredited within the year. And so I remained the forensic pathology director for fellowship until I left after 18 years.
And within your role of teaching, did you hold various ranks as a professor?
I started out as an assistant professor, and when I left after 18 years, I had reached the rank of full professor.
Okay. Doctor, do you have any publications to your name?
I do.
And could you briefly, I'm not looking for a sort of a rundown of publication by publication, but could you give us a sense of the topics of your publications and perhaps roughly how many?
The topics range from, pediatric deaths, toxicology deaths. I had some publications during my graduate work, so it was unrelated to forensic pathology. And I have co-authored some chapters in a textbook about unexpected pediatric deaths. Those chapters had to do with autopsy testing for bacteria and viruses in children who've died suddenly. Another chapter had to do with working collaboratively with other agencies and specialists, and a third chapter had to do with trying to address prevention and family needs when a child dies suddenly and unexpectedly.
And so roughly how many publications is that?
I've not counted them. I have maybe half a dozen or so journal publications and several abstracts from national meetings where I've presented posters and papers.
Okay. The journal publications, have any of those been in peer-reviewed journals?
Yes.
And for our benefit, what is a peer-reviewed journal?
A peer-reviewed journal is a journal that will accept papers from physicians, scientists, and one of the editors will assign someone, a peer, so someone in that specialty or field, to review the paper anonymously.
Okay. And if you said it, I may have missed it, but have you served as an editor of a publication?
I am currently an associate editor for the American Journal of Clinical Pathology, which is the largest pathology journal in circulation in the world today. And my section is for autopsy and forensic pathology.
Doctor, are you board certified in any area or areas?
I am.
And which areas?
I'm board certified in anatomic and clinical pathology and in forensic pathology.
Do you maintain any current licenses?
I do.
And what are those?
I have a physician's license to practice medicine in Missouri.
Mr. Nelson, let me just interrupt.
Yes.
In this pause, as has been our practice, I think, when you're finished with the qualifications,
Sure.
I will give Mr. Barnard a chance if he wishes to inquire as to qualifications.
Sure.
Go ahead.
I think I will pause there.
Okay.
Thank you, Doctor.
Mr. Barnard, would you seek to inquire about
Your Honor.
qualifications?
Excuse me. Your Honor, I will not question Dr. Turner with regard to preliminary qualifications. I think they're adequate. However, I do reserve the right to cross-examine her regarding those in,
Opinion.
yes, when the time.
So you have
comes.
no objection as to
No,
her?
I do not.
Okay.
No.
All right. Then you may continue, Mr. Nelson.
And Your Honor, I would ask that Dr. Turner be recognized as an expert in the field of forensic pathology.
She will be.
Doctor, are you familiar with the case of Ariana Hoffman?
Yes,
And in this particular case, have you reviewed and considered certain records?
I have.
And what records have you reviewed?
I reviewed medical records from Blessing Hospital and medical records from Cardinal Glennon Children's Hospital. I reviewed records from the St. Louis City Medical Examiner's Office. I reviewed police investigative reports, grand jury transcript. As part of my review of the records from St. Louis City Medical Examiner's Office, I also reviewed the autopsy photographs and the autopsy slides.
And when you refer to autopsy slides, are you referring to the microscopic slides?
Yes.
Okay. Approximately when did you review those records?
I think it was 2019, 2020, somewhere around there.
Okay. Following your review of those records, did you arrive at an opinion as to the cause of Ariana's death?
Yes.
Okay. And we will get into the weeds of that shortly, but for summary purposes right now, what was your opinion arrived at within a reasonable degree of medical certainty?
Yes.
And what was that opinion?
That Ariana had natural disease process that included an infection. Her body overreacted to that infection in a process known as sepsis. And as part of that process, she developed blood clots that traveled to her brain and caused her to have a stroke. The microscopic slides show that the blood clots pre-existed her admission to Blessing Hospital on January 20th. So this was a process that started before January 20th, but became critical on January 20th.
Okay. So let's start with your opinion that Ariana had an infection. What did you observe within the medical record that would support your opinion that there was an infection?
The first chest x-ray she had at Blessing, less than an hour before she was admitted there, showed that she had abnormalities of her lungs consistent with pneumonia. Additionally, the laboratory study showed that she had markedly elevated white blood cell count. White blood cells are the components in your blood that respond to infection and fight infection. She also had a low body temperature. We always think of fever as being a sign of illness, but in some instances, a low body temperature can also be a marker of infection.
Was there anything pertaining to a urinalysis that had been done?
Yes.
And what was relevant with regard to that?
The first urinalysis, I don't really recall anything standing out from that. It was the second urinalysis that showed that she had glucose in her urine and ketones, which ketones are something that develop when you have diabetic ketoacidosis. So in someone who has undiagnosed, untreated diabetes, an infection can trigger this metabolic condition where ketones are produced.
Was there any sort of testing of Ariana's ability to clot blood?
Yes.
And how was that relevant to this discussion?
It's relevant because so some people, an infection can trigger this sepsis reaction. That's like some of the people who had COVID and were able to stay home and get over it, and other people had COVID and ended up in the hospital because their bodies overreacted to it. So part of that process is when sepsis develops, it triggers another abnormality in the body, and that is abnormal clotting and bleeding, which is known as disseminated intravascular coagulation. We call it DIC for short, for obvious reasons. But the Ariana's test showed that she had an inability to clot some of her blood. So there were abnormal clotting studies where the clotting took too long or the test showed that her clots were taking too long, her blood was taking too long to form clots. Additionally, over the course of her hospitalization, her platelets dropped. Her clotting was so abnormal that the treating doctors administered her blood products to help improve her clotting. They also injected her with vitamin K, which helps improve clotting.
Now, there was some testing that had been done at Cardinal Glennon in an effort to determine further if there was an infection, correct?
Yes.
And what did you notice in reviewing the medical record with respect to the testing that had been done at Cardinal Glennon?
It was very limited testing, and it was, and I didn't have the actual laboratory reports, just doctors reporting on the lab reports. So I never saw the actual test results, but it was reported, for example, that viral PCR was negative, but that doesn't give me any information. I don't know what the specimen for that test was, if it was urine or blood or sputum. It was very vague.
Okay. With, let's change gears just a little bit and talk about the autopsy. Given everything that you've described so far, was there anything surprising about the autopsy that was done in regard to the lack of certain testing?
There was no testing for viruses or bacteria or fungi in the autopsy examination.
And would you have expected testing then,
Yes,
given the situation that you have been describing?
yes.
And what would further testing have benefited anyone?
It would have investigated what organisms were involved in Ariana's body having that sepsis reaction.
What types of specimens or cultures could have been obtained during the autopsy that would have added to this discussion?
A number of them. And when an autopsy is performed, you only have one opportunity to collect these specimens, and that is at the beginning of the autopsy, before everything is moved around and examined and handled. So blood could have been collected and submitted to the microbiology lab for testing for bacteria, fungi, and viruses. Cerebrospinal fluid, that's the fluid that bathes the brain and the spinal cord. That could have been collected to test for the same. Testing of the cerebrospinal fluid is important when you want to investigate something like meningitis or encephalitis. Lung biopsies, the pathologist has the advantage over treating physicians at hospitals and having direct access to the lungs. So biopsies of the lungs could have been taken and submitted to the microbiology lab for that same type of testing, bacteria, fungi, viruses. It's also recommended that stool be collected and submitted for viral cultures and looking for ova and parasites. Those are the primary samples.
Is there any reason why it would have been too late to obtain those samples at the time of the autopsy for purposes of contamination or decomposition or anything like that?
No.
Okay. Could you explain for us what the nature of a D-dimer is?
A D-dimer is a marker that shows evidence of blood clotting in the body. It's something that, for example, people who get sick from COVID and develop blood clots, one of the ways that doctors test for that is to measure D-dimer. So with DIC, that disseminated intravascular coagulation, at the same time you can have abnormal bleeding as well as abnormal clotting. So the clotting tests were abnormal to demonstrate that Ariana wasn't clotting blood for those specific tests, but she also had markedly elevated D-dimer tests. Like the normal is less than 200 nanograms per mil. Ariana's was so high that all they could say was greater than 1,600 nanograms per mil. So it was clear that she had formed blood clots.
Okay. And does that level of test indicate anything about the level or extensiveness of clotting in Ariana's body at that time?
I don't know about that, but from studies I've read, that concentration of D-dimer is a poor prognostic indicator, meaning it was showing that she wasn't likely going to survive.
What can you tell us about what the medical record indicates to you in terms of when this clotting may have started in Ariana?
So a few things. So as far as the hospital records, there's one thing, and that's the D-dimers, plus the CT scan of her head where the radiologist identified what they described as blood products in and around the brain. That's not a normal description. That's an abnormal finding. Then with the autopsy examination, there were blood clots in the skull cavity after the skull cap was removed and the brain removed. There were blood clots coming out of different vessels in the skull. One of those was biopsied for microscopic examination. The microscopic examination shows that this blood clot had been undergoing the process of healing, or organization is how pathologists refer to it. And the cell components, the parts of that blood clot microscopically that showed healing, showed that they'd been there. The cell types only present 8 days or longer prior to Ariana's death. So this process had been going on before January 20th, many days before.
When Ariana was at Cardinal Glennon, there was a CT that was done.
Yes.
What, if anything, does that CT exam contribute to our discussion here today?
The overwhelming finding of that CT exam was that of hypoxic ischemic encephalopathy, or HIE, which stroke causes HIE.
In viewing the microscopic slides, did you see any evidence that would indicate that there was clotting that was traveling through the vascular system?
Yes.
And what was that evidence?
There were small blood clots. So on microscopic examination, small blood clots in small blood vessels in different organs, in the lung, in the kidney, in the eyes, in the brain.
Okay. And if I use the term laminar or laminar flow, what does that suggest?
The laminar blood flow refers to blood flow in a blood vessel. So with laminar blood flow, the blood elements form different layers. So red blood cells form one layer and white blood cells form another. And if there is a blood clot that forms in a blood vessel, it will have evidence of that laminar flow. You'll see alternating red blood cells with white blood cells with red blood cells. So it's that layering effect.
And is there anything that that you observed that would indicate in terms of lines on the clots?
In the brain, the microthrombi in the other organs have a different way of forming, but the ones that were in the brain cavity after the brain was removed and they were coming out of the blood vessels, those blood clots had those lines, those laminations. In pathology, we call them lines of Zahn, after a pathologist named Zahn first described them.
Okay. And why is that significant, that those that particular material had lines given the location of that material?
That indicates that material, that blood clot, came from a blood vessel. So blood vessels are under pressure, and that's why you get those lines of Zahn. So that's called laminar blood flow. And other spaces, like the subdural space, doesn't have that same configuration, that same pressure. So just imagine a pipe, that blood is flowing through a pipe and forming those lines, those laminations, and then at the end of the pipe is emptying into a bucket. When that blood enters or leaves the pipe into that open space of a bucket, it doesn't have the same forces acting on it, and that's called turbulent flow. So you lose those lines. So you identify a blood clot coming from a blood vessel by virtue of those lines of Zahn. A blood clot from the subdural space, which isn't tubular, doesn't have the same vascular forces, doesn't have the heart pumping blood through that space. That is turbulent flow, and it does not have lines of Zahn. It doesn't have lamination.
And so kind of bringing this around to the issue at hand, what does the fact that those clots were of that nature in that location, how does that contribute to your finding in this case, or your opinion in this case, that this was a natural cause of death? Different
Aspects of that. So those microscopic lines of Zahn correlated with the autopsy photograph showing the blood clots coming out of the different vascular spaces at the base of the skull. Those blood clots cause stroke. Stroke is not something you can diagnose on autopsy when it happens within a brief period of time, unless the stroke becomes hemorrhagic, but not all strokes bleed into the brain. Many strokes are what we call ischemic, so you don't see an actual stroke on autopsy. But we have that imaging study, the CT scan showing the hypoxic ischemic encephalopathy. I'm sorry, I forgot where I was going with that. Your question again?
How does this contribute to your ultimate opinion in this case?
So, and then microscopically, that blood clot with the lines of Zahn had changes that showed that this blood clot had been in existence before January 20th. So this is a piece of my opinion that this was a natural disease process that started before January 20th and became critical on January 20th when Ariana stopped breathing.
We have heard earlier in this courtroom the term cerebral sinovenous thrombosis. And there's been some description of that. Could you relate to the ladies and gentlemen of the jury what role that plays in our discussion here today?
That cerebrosinovenous thrombosis, or CSVT, is what I'm describing, the blood clots from a blood vessel. The blood vessels that surround the brain are venous structures in the dura. So you have the scalp, you have the skull, and then underneath the skull you have this fibrous membrane called the dura mater. The dura mater collects the venous blood from the head into the sinuses that it contains. So the dura mater has these tubular structures that are vascular structures, venous structures. The blood clots that are demonstrated in the autopsy photo and the one that was biopsied for microscopic examination came from those sinus spaces.
Is it rare or is it common for CSVT to be associated with illness in children?
Illness is one of the most common causes of CSVT in children.
Okay. Are there other causes?
Yes.
And what are those?
Well, when I say illness, I mean bacterial, viral, or fungal. Anemia can cause CSVT. Dehydration can cause CSVT. Diabetes, hyperglycemia has been associated with CSVT.
Let's talk a little bit about eyes. When there is, in the setting that we have been discussing here today, when there is some type of hemorrhaging either in the retina or in the optic nerve sheath, are there natural explanations for that?
Yes.
And what is the natural explanation?
Well, the more common cause of those hemorrhages is increase in intracranial pressure, so brain swelling. And when Ariana had her eyes examined in the hospital, there was already evidence that she had increased intracranial pressure. And I would add, so you asked me natural causes, so increased intracranial pressure is one, and DIC, so the abnormal clotting and bleeding also has been associated with retinal hemorrhages.
Okay. So it is retinal hemorrhaging and optic nerve sheath hemorrhaging are not specific to any type of abusive head trauma.
No.
Doctor, you've referred to the microscopic.
Hang on just a second, Mr. Nelson.
I just wanted to know if I could have some water, please.
Yes, could we get some water? Okay, you may go ahead, Mr. Nelson.
Thank you. Doctor, you've referred to the microscopic slides that you've reviewed in this case. In viewing these slides, you viewed them through a microscope, correct?
Yes.
And was there a camera attached to your microscope?
Yes.
And that camera, does that allow you to generate images of what you are viewing through the microscope?
Yes.
And in this particular case, did you take images of what you had reviewed of the microscopic slides?
Yes.
And based on those images, did you prepare a series of PowerPoint slides or diagrams to assist with your testimony here today?
Yes.
John?
And for the record, Mr. Barnard, have you had the opportunity to view the exhibits that counsel is about to hand the witness?
Yes.
Okay.
Doctor, I'm handing you what was previously marked Defendant's Exhibits 1 through 13. Would you take a look at those, please?
Okay.
And do those fairly and accurately represent the images that you viewed and then generated for purposes of today?
Yes.
Your Honor, I would ask for demonstrative purposes that Defendant's Exhibits 1 through 13 be admitted and published.
No
Any objection, Mr. Barnard?
No, Your Honor.
All right. Then they will be admitted. And any objection to their being published, Mr. Barnard?
No, Your Honor.
All right. Then they will be published without an objection.
Doctor, I'm going to hand you a laser pointer. Hopefully that will be beneficial.
Do you want the lights off, Mr. Nelson?
Yes, please.
Okay.
So, Doctor, I'm displaying Defendant's Exhibit 1 here. And can you tell us what this is?
This is a photomicrograph of Ariana's lung, and it's showing that her air spaces are full of inflammatory cells, and that is how the diagnosis of bronchopneumonia is made. Bronchopneumonia develops typically from bacteria after there's been a viral infection, either after or during a viral infection. So we're looking at evidence of infection in her lung.
And specifically the white spaces that we see in the photograph, what are those spaces?
The white spaces are normal. That's where air goes into the lung to provide your lung with oxygen and your lung to offload the carbon dioxide. So it's the spaces that that have the small specks in it that are abnormal, that show pneumonia.
And when you refer to the spaces with small specks, could you use that pointer to point to perhaps what you're referring to?
Yes. My aim is any good at this distance. But that's an alveolar space, an air sac in the lung, and those are inflammatory cells in it. Some of the air spaces have many more inflammatory cells in it. All this space should have circles like that, clear spaces with a thin line between them, but instead we're seeing occasional clear spaces with many other spaces full of protein and inflammatory cells.
So the inflammatory cells are the small, darker spots?
Yes.
This is Defendant's Exhibit 2. Is this also from the lung?
Yes, this is higher magnification, so you can see a little bit more detail than the last image. But this is an airspace. That's an airspace. These once were filled with air, but now they're filled with inflammatory cells. This airspace has this pink lining to it that's abnormal, and that's called a hyaline membrane. Hyaline membranes form in the lungs either by virtue of a viral infection or from sepsis. Those are the two things that cause hyaline membranes in the lungs.
What has occurred for the hyaline or hyaline?
Hyaline.
Hyaline. What has occurred for the hyaline membrane to form?
Viruses and sepsis damage the lining of the air sacs of the lung, and those cells lining the air sacs die and undergo a process of necrosis where they form this membrane. So this represents alveolar lining cells that have been damaged and died.
This is Defendant's Exhibit 3. And this is also from the lung, correct?
Yes.
Now, this is significant for different purposes. Why is that?
This represents what DIC looks like on an autopsy. So with DIC, you can have abnormal bleeding in different parts of the body, and at the same time, you can have these small blood clots form in blood vessels. And the blood clots start forming by fibrin. Fibrin is a mesh that circulates in the blood, and it helps form a blood clot. So it's a mesh that traps red blood cells, and it traps platelets, which also help form blood clots.
And so the blood clots in these images are represented by what specifically?
I'll point out so that's a microthrombus, that's a microthrombus, and that's a microthrombus. And these two are, this one's completely blocking blood flow here. This one looks like it may have blocked blood flow at one point. This one is surrounded by blood flowing, so it's not completely blocking the blood flow. But this one is younger than these two. This one is made up primarily of fibrin and some platelets. These have undergone some healing, so it's more of a hyaline fibrin clot.
And how is it that you know that the one on the left is younger than the others?
The granular appearance of it, it's not as solid looking as the areas in these clots.
This is Defendant's Exhibit 4. This is also a blood clot.
Right, another microthrombus I found on microscopic examination of the lungs. So that's the microthrombus there.
And this, would this have been from a different area of the same slide, or?
Yes.
Okay. This is Defendant's Exhibit 5. And so blood clots were not located just in Ariana's lungs, correct?
Correct.
And Defendant's Exhibit 5 is blood clots in another location. What location is that?
That's in the dura, that fibrous covering of the brain that drains venous blood from the head into those sinus spaces in the dura. So these are draining venous spaces in the dura, and they were headed towards the larger sinuses.
Defendant's Exhibit 6. And this is from the brain, correct?
This is from the biopsy of blood material, blood clot, taken from the skull cavity. And what this shows are different changes to the blood clot. So this had been in a dural sinus, and it had been there for enough time for there to be healing. This is all hyalinized fibrin that has healed. If this was fresh, if it had happened on the 20th or later, you would see just red blood cells alternating with white blood cells. But now we've got evidence of healing with this hyalinized fibrin, and you can appreciate some alternating areas of fibrin and red blood cells. So when a blood clot forms, the body does 4 different things to address it. One is it'll try and break it down, a process called lysis. So anybody who has had a blood clot in their coronary artery, if they catch it fast enough, they'll get injected with an enzyme to lyse that blood clot and reopen that blood vessel. So the body can address it by trying to break down the blood clot. Another thing that can happen to a blood clot in the body is it can get bigger. So you can have a blood clot form and more layers get added to it over time. A third thing that can happen to a blood clot that forms in the body is that it can break apart, and those pieces can travel further downstream and cause problems further downstream. And the last thing that can happen to a blood clot that forms in a blood vessel in the body is that it undergoes the healing process where it's kind of like forming a scab and then a scar. So you have different cells change the appearance of the blood clot, and it can shrink because that hyalinized fibrin represents essentially like scar tissue. So it can shrink down, it can grow new blood vessels in the middle of it. And those four things can happen to the same blood clot at the same time. So they're not mutually exclusive. There's no time order of what happens when, except for the healing process. The healing process follows sequential pattern.
And following up on that, what can you tell us about the lower right area of this particular image?
My right, there it is. The lower right here,
Yes.
that is fresh blood, so that's newer. So this is older and this is newer. So you have evidence of healing and new addition of the blood. So healing and growing in size.
Defendant's Exhibit 7.
This is showing the lines of Zahn, that laminar appearance of blood clots that form in a blood vessel. So you have alternating red blood cells with fibrin and white blood cells, red blood cells, fibrin stripes with white blood cells, and same over here. So you have this layered appearance.
Defendant's Exhibit 8. This refers to endothelial cells. Can you point to, on this picture, where the endothelial cells are?
They are on the surface of this healing blood clot. They're sort of pancake shaped, flattened on the surface. The endothelial cells come from a blood vessel.
This is Defendant's Exhibit 9. This comes from the liver. And what can you tell us about there are darker areas in this particular image, correct?
Correct.
And what can you tell us about those darker areas?
Those darker areas represent damage to the liver from sepsis. Ariana's blood pressure dropped, and that causes damage to the liver and other organs. But in the liver, it's represented by those dark areas where the liver cells are damaged. And that correlates with her laboratory studies showing that her liver was releasing some enzymes because the liver cells were damaged.
This is Defendant's Exhibit 10, and it refers to the subarachnoid space. We have heard some discussion of that previously in this courtroom, but could you remind us again what the subarachnoid space is?
So the layers of the head, you have the scalp, the skull, and then the dura mater, that fibrous, membranous covering of the brain. And then beneath the dura is the arachnoid. So subarachnoid means beneath the arachnoid. And that's a potential space between that thin, translucent covering and the brain.
And so this image is it represents blood clots in that area.
Yes.
Defendant's Exhibit 11, blood clots in the blood vessels of the brain. Is this from a different area of the brain?
Yes.
And so how would this be different from the last image that we saw?
In the last image, those were blood vessels outside the brain, closely associated with the brain, but they were outside the brain in that space between the arachnoid and the brain. These are blood vessels in the brain itself.
Defendant's Exhibit 12. It refers to ischemic microinfarcts. What are ischemic microinfarcts?
Ischemic refers to the lack of blood flow. There's no blood flow in those areas because there are blood clots, which are those balls, those circles that you see. Oops, I'm doing it the wrong way. There and there, but you can see multiple. They almost look like targets. So the ischemic means that there's no blood flow and there's no hemorrhage. And microinfarcts means that these are small, that they can only be observed microscopically.
And so in this image, the darker, smaller circles in the center of the larger, lighter circles, those would be the blood clots themselves?
Yes,
And then, so the lighter areas surrounding the darker circles would be the damaged tissue. Is that correct?
yes.
And finally, Defendant's Exhibit number 13. Can you please describe for us what we're looking at here?
We're looking at photomicrographs I took of Ariana's eyes. Her eyes were removed as part of the autopsy examination. And again, I found microthrombi in the eyes. So here's one in a blood vessel. This is the retina here. This is in the retina as well. This is in the soft tissue close to the eye. So there's some fat and muscle that surround the eye. So there's a blood clot in a blood vessel there. And then there's a newly formed blood clot here in the optic nerve sheath.
Your Honor, can I have just one moment, please?
Yes. You want the lights back on?
We could hold off on that for just a second.
Sure.
This is what was previously admitted into evidence as People's Exhibit 18. And this was a photo taken during the autopsy, correct?
Yes.
And doctor, what can you tell us about this area in the lower right?
That is a blood clot.
And is that a blood clot in a venous structure?
Yes, the sigmoid sinus.
Thank you. We can turn the lights on. Thank you. Doctor, given everything that we have discussed here this afternoon, would you tell us what your medical opinion is, again, within a reasonable degree of medical certainty in this case?
Yes. Ariana died from natural disease process. That disease process began before January 20th, as evidenced in the microscopic slides of the blood clots in her head. She had evidence on arrival at Blessing of a lung infection, and microscopically, that lung infection had evidence of bacterial pneumonia that followed viral pneumonia. And her laboratory study showed that her body was overreacting to the presence of that infection by developing sepsis, which is a process in which the different organ systems in the body shuts down, and sepsis triggers the process known as DIC, where there's abnormal bleeding and abnormal blood clotting.
Thank you, doctor. No further questions.
Okay, ladies and gentlemen, it's 3:15. We've completed the direct examination of Dr. Turner. I anticipate there's going to be some cross-examination, but I believe this would probably be a good time to take a break. So we will adjourn for about 10-15 minutes. If you'd be back in the jury room, perhaps at 3:25, and be ready. We'll begin cross-examination at 3:30. So,
All right.
yes, I would admonish you again, as I have on many times, not to discuss the case. Don't do any independent research. Don't let anyone communicate with you about the case. So at this time, you're adjourned. Okay, this is case 18 CF 492, People versus Travis Wiley. Mr. Wiley is present in court with his counsel, Mr. Nelson. The people are represented by Attorney Barnard, who is present. The witness, Dr. Jane Turner, is on the stand. We're outside the presence of the jury. Let's have the jury. Okay, the record should now reflect that the 12 members of the jury, the 3 alternate jurors, are all present in the courtroom. Mr. Barnard, you may cross-examine.
Thank you, Your Honor. Dr. Turner, I want to begin with the testimony that you just gave. And then we will move forward to some other areas. You began by stating that the disease process that ultimately caused the death of Ariana began before May the 20th, correct?
January 20th, yes, sir.
Excuse me, January 20th. My error. January 20th of 2018, correct?
Yes, sir.
And in fact, if my math is correct, you restated that another 2 times. Do you have any reason to disagree with my math on that?
No.
And I take it that you shared that fact or information with us because it was significant to you, correct?
It's also the evidence in the autopsy microscopic slides.
And I'm going to get to that. But my question is that information that you shared, that the disease process occurred, specifically I think the clots occurred before January 20th, was significant to you, right?
It is significant, and it's the evidence.
My question to you was, it was significant to you, right?
Yes.
Right. In fact, you finished with the notion that this disease process began before January 20th, didn't you?
Yes.
Let's talk about some other things you shared in the course of your testimony. Doctor, you mentioned that there were ketones found in the course of this investigative process that you engaged in, right?
There were ketones in a urinalysis.
Okay. And that relates to, in fact, you said that it's related to, or associated with, at the very least, diabetic ketoacidosis, right?
Yes.
That's the term you used. And I take it, doctor, that this piece of your diagnostic picture was, again, significant to you in forming your opinion, right?
Yes.
Doctor, you then went on to mention that Ariana's D-dimer values were basically off the charts. Fair?
Yes.
In fact, they were so off the charts that they presaged her death.
Yes. That's what current studies show, that there's a correlation with that high D-dimer with a poor prognosis.
What you said was they were so severe, they in and of themselves indicated she wasn't going to live, didn't you?
Those were not my words, that her prognosis was poor.
Beyond poor, right?
Yes. There was a poor chance of survival.
And again, that was significant to you, I take it. Fair?
Yes.
You stated also that bronchopneumonia develops following a viral infection, right?
Yes, patchy bronchopneumonia.
follows a viral infection.
That's correct.
And of course, you're aware, and then you even refer to the fact that viral PCR testing was done at Cardinal Glennon Children's Hospital, right?
I don't know what the specimen was for the viral
And I
PCR.
get all that, I'm with you, but the fact of the matter is that viral PCR testing at Cardinal Glennon Hospital was negative, right?
That's how it was reported by a physician. There was no lab report for it.
Fair enough. But the conclusion was there, wasn't it?
It doesn't correlate with the lungs if you don't know where that specimen came from.
Doctor, I apologize, but my question was, the conclusion was in the records, wasn't it?
And it was reported by a physician.
You described, in conjunction with the slides, the appearance of changes in the lung that indicated to you that they're, and I think you described it as patchy bronchopneumonia, right?
Yes,
Or evidence of patchy bronchopneumonia, right?
yes,
You described, I think, their location in the lungs.
that's correct. The bronchopneumonia was in the lungs.
And you described the significance of those changes on the slides, right?
Yes,
You described the progression of this pneumonia, the patchy bronchopneumonia, in terms of compromising the ability to breathe, I think is how I understood it, right?
yes,
By filling up the air spaces, right?
that's correct.
You went on to comment on and describe microthrombi in the eyes, didn't you?
Yes,
And the significance of that, and I think it had to do with showing microclots, right?
yes,
You concluded by saying that the disease process began with viral pneumonia, right?
likely, yes,
Followed by bacterial pneumonia, correct?
yes,
And that triggered this process involving sepsis, then CSVT, also in the presence of DIC, right?
yes,
Leading to a stroke that caused her death.
yes,
Now, all of the things that you shared with us, I'm going to assume they were significant to you in coming to the conclusion that you did. And I'll start with this disease process began before May 20th because, well, this disease process began before May 20th. Agreed?
January 20th.
I'll get it right eventually. My apologies. If you've been here all week, you've seen a lot of this. Again, I apologize. January 20th. I'm looking at your report. And it is 7 pages long. Covers a lot of ground. Do you have your report in front of you?
I do not.
Do you remember it?
No.
Well, I'm looking at a copy of your report, and if council's got one,
I
And that
have,
would help, we'll share it with you, but here's where I'm going.
I have one in my briefcase.
Feel free to pull it out if you want to.
Go ahead, you may do that. And you have it?
I do, thank you.
Okay, all right. Go ahead, Mr. Barner.
Doctor, you point to me in that report where it says this disease process began before January 20th, 2018.
I don't state that explicitly, except in my photomicrographs where I show the endothelial cells and the healing thrombus.
Thank you, doctor. My question was, point that out to me in the report where it says this disease process began before January 20th. It's not in there, is it?
It's in the photomicrographs, which is part of my report. I submitted those with the report.
It's not in your report, is it?
That is, a photomicrograph is part of my report.
Show me the words, this began before January 20th, in your report.
I can show you the photomicrograph that shows the arrows to the endothelial cells.
Thank you, doctor. Not my question. That statement is not in your report, is it?
Not in those words, but in demonstration with the photomicrographs.
Doctor, point out to me where it says in this report, this 8-page report, the word diabetic ketoacidosis.
It doesn't say that.
Point out to me in this report where it uses the term ketone.
I don't know if I included that in here.
I'm not asking you to trust me, but I'm going to suggest to you that word is not in there.
Okay. It's in the medical records.
It's not in your report, is it?
I don't know.
Doctor, point out to me where in this report, this 7-page report, it refers to and uses the words microthrombi in the eyes.
Again, it's in the photomicrographs.
I'm talking about the report, doctor.
That I am insisting that the photomicrographs are part of my report.
Where do those words appear in that 7-page report?
You know my answer.
I want to hear it.
It is in the photomicrographs that you are choosing to exclude. I submitted that as part of my report.
This is not a trick question, doctor. Do those words appear in your report?
And it's not a trick answer. My report includes those photomicrographs.
I'll take that as a yes. They do not appear in the report.
No, they do appear in my report, in the photomicrographs.
You know, you submit this report, and I understand your role in doing that. But you understand that when you submit a report like this, people are going to rely on it, right?
Yes,
Yeah. And you want to state your significant findings in your report, don't you?
and I do discuss the high blood glucose that Ariana had.
I'm referring, and I apologize, doctor, to microthrombi in the eyes.
And again, that is in my report.
May I approach?
You may. And are you gonna have it marked?
I will.
With your- okay.
Next one.
21.
21, thank you. Doctor, I'm going to show you what's been previously marked as People's Exhibit 21 for identification. Take a look at that. Same report you have in front of you, right?
Yes,
Where did the words microthrombi in the eyes appear in that document in front of you?
they're not. They're in the photomicrographs, which I submitted with this report.
Likewise, the clotting began before January 20th. That does not appear in that 7-page report, does it?
Similarly, it's in my photomicrographs.
Likewise, the term ketoacidosis, diabetic ketoacidosis. Fair?
That's correct.
All right, thank you, doctor. You referred, doctor, to a photograph, I think that Mr. Nelson shared with you, of the bottom of the brain, after the brain had been removed, bottom of the skull after the brain had been removed.
Yes, it was the base of the skull.
And you described what you interpreted as a clot, right?
Yes,
You weren't there at the autopsy, were you?
that's correct.
You didn't perform it?
That's correct.
You didn't watch it?
That's correct.
You didn't talk to Dr. Williams regarding what he saw or interpreted, right?
That's correct.
This is a photograph, right?
Yes.
And on page 4 of your report, about halfway through the paragraph under cerebral sign of venous thrombosis and stroke, there is a sentence that begins with the words, "the autopsy photographs." You with me?
Yes.
And I'll quote, the autopsy photographs show marked congestion of the sinovenous system, image 11, and the presence of thrombosis from the sinovenous system. This thrombotic material was not described as such in the autopsy report, but rather sampled for microscopy and labeled as subdural hematoma in slide H. Did I read that right?
Yes.
Again, back to the content of your report, your 7-page report, Doctor. Where do the words viral pneumonia followed by bacterial pneumonia appear?
It doesn't.
With regard to the clots, or the slides of the lung tissue that you referred to, where is that, and help me with that, Doctor, where is that discussion about the content of the slides? I think I know where it is, but help me with that. I think it has to do with findings on the autopsy, microscopic examination having to do with demonstrating patchy bronchopneumonia.
I describe thromboses present in the biopsies of the lungs, kidney, ovary, optic nerve sheath, dural sinus, and pia arachnoid.
Where, with regard to the discussion of the slides, which I believe begins on page 3, and I'll quote, microscopic slides of the lungs, however, demonstrate patchy acute bronchopneumonia. No gram stain was performed on the tissue to identify bacteria. Where does it go on to describe the specifics of those slides regarding bronchopneumonia, their significance or their progression?
So it's generally accepted in medicine that bronchopneumonia interferes with oxygen exchange.
I get that, Doctor. My question is, where does that discussion that you shared with us here in the courtroom appear in that report?
It's not in there.
I want to move, Doctor, to, I take that back. One more item I want to discuss with you concerning your testimony about D-dimer in particular. Again, your testimony was that those numbers were so off the charts, they basically point to a prognosis, as you describe it, as very poor. Correct?
That's my understanding from the medical literature.
Yeah. Let me quote to you from your report, Doctor. The discussion of D-dimers appears on page 4, top paragraph, and you talk about the numbers, greater than 1,600 nanograms per milliliter, right?
Yes.
Okay. And you go on to say that the abnormal clotting tests, being the D-dimer test, presented a risk for abnormal and easy bleeding. Where does it say in there that this was so severe that it augured her death?
It doesn't say that. That's something I recently reviewed in a medical journal.
Doctor, let us now move on to the other findings in your report. And I'm going to compare that to what appears in the medical records. Let's start with the blessing records, okay? You looked at the reports from Blessing Hospital particularly, it sounds like to me anyway, the radiology report or reports, correct?
Yes.
And first of all, you are not a radiologist, right?
That's correct.
But there is a series of reports, kind of a progression from a radiologist in that blessing record, isn't there?
Yes.
Doctor, where does the word pneumonia appear in that radiology report or reports?
It doesn't. It refers to changes in the lungs that are consistent with pneumonia.
Where do the words impression pneumonia appear?
It doesn't.
How about viral pneumonia?
No, they describe changes in the lungs that are abnormal that are consistent with pneumonia.
Bacterial pneumonia?
They're not there. That's on the microscopic slides that there's pneumonia.
Let's talk about the changes, okay? And that's a fair point. I believe the first in the series, and I'll share these with you if you don't recall them. Dated January 20th, 2018 at 15:47. That'd be 3:47 in the afternoon. It's a radiology report. I'll go to the impression. The distal tip of the endotracheal tube is within the right main stem bronchus. Endotracheal tube should be pulled back approximately 5 centimeters. Finding number 2, diffuse right upper lobe parahilar infiltrates. Finding number 3, consolidation of most of the left lung. I take it that is what you are interpreting as pneumonia.
Consolidations is a way that radiologists and pathologists describe pneumonia, and infiltrates is another radiologic finding consistent with pneumonia.
Maybe I was unclear. I take it that is what you interpreted as pneumonia, correct?
That's what I'm saying, yes. It's consistent with it. I'm not saying it's diagnostic. I'm saying it's consistent with it, and the microscopic slides confirm that diagnosis.
Fair enough, doctor. Let's go on to the next one. 15:47, roughly the same time. Impression, the distal tip of the endotracheal tube is at the carina. The endotracheal tube should be pulled back approximately 1 centimeter. Finding 2, diffuse right upper lobe and parahilar infiltrates. Finding number 3, infiltrates in the lung, left lung, cannot be excluded. Again, I take it that was part of your thinking in forming your own impression, right? Of pneumonia?
It's not an impression, it's a differential diagnosis. So infiltrates are consistent with pneumonia.
Doctor, I've got it in my hand, and I'm going to represent to you under the impressions section of that interpretation by a radiologist. Nowhere does it appear the term pneumonia. all right?
That's correct.
Or likely pneumonia.
That's
Okay?
correct.
Or consistent with pneumonia.
That's correct.
Or suspicious for pneumonia.
Okay.
Or rule out pneumonia.
Okay.
All right? So then let's go to the next one, which is approximately, again, the same time, or maybe 2 minutes later, 3:49. Impression. Endotracheal tube is at the carina with complete collapse of the left lung, likely due to underinflation. A follow-up radiograph demonstrates improved positioning. Please see separate dictation. So the impression there is that, according to the radiologist, which you are not, that the findings are likely due to underinflation of the lung. Right? I'll share it with you if you think I didn't read it right.
Infiltrates would not be consistent with underinflation.
Likely due to underinflation. That's what the impression is.
For one of those,
Any reason to disagree with me that I read that?
if you could read it again, please.
Sure, be happy to. Endotracheal tube tip is at the carina with complete collapse of the left lung, likely due to underinflation. Follow-up radiograph demonstrates improved position. Any reason to believe I read that wrong?
No, the collapse of the lung is entirely different appearance than infiltrates and consolidations.
Let's go to the.
So we're talking about something entirely different.
Let's go to the next radiology interpretation. 1634. That'd be maybe half an hour, 40 minutes later. Impression is the radiologist. Endotracheal tube tip has been repositioned with tip now in the right mainstem bronchus. Patchy bilateral opacities, probably atelectasis, secondary to underinflation. A follow-up radiograph demonstrates improved position. Finally, 1635, a couple minutes later, from the radiologist impression, endotracheal tube is in good position, diffuse ill-defined consolidation throughout both lungs, probably secondary to underinflation. No definite focal consolidation. Now, doctor, if you're willing to trust me that I read you the pertinent parts of that impression from the radiologist, no mention, no use of the word pneumonia, correct?
That's correct.
Either diagnosis, impression, consistent, or suspicion of, correct?
That's correct.
Now, let us go to the Cardinal Glennon records. I know you don't have them in front of you, and I have those records if you need to look at them. But I'm going to refer to a portion of the Cardinal Glennon records having to do with lung films, all right? And there is reference to, I believe that the term used was in one film, central predominant airspace opacities, right? Kind of like it's not dark as normally would be, correct?
Yes.
Opacity can be due to, and often is due to, underinflation, right?
It's often due to pneumonia, too.
Would you have any reason to believe or disagree with me that there is no reference to pneumonia in that report?
No, they say opacities, and microscopically there's pneumonia. There's not
And you're
atelectasis.
saying it's consistent with pneumonia, as you've shared before. But my question to you is, does the word pneumonia in any of its variations appear in that report?
No, but pneumonia appears in the autopsy.
And in fact, in further discussion of films, I think there's reference to, particularly in the pediatric critical care progress note of January 21, some central opacities. Again, not dark, it's kind of getting hazy, right?
Right, hazy from air spaces being filled up by inflammatory cells and edema fluid.
We're not communicating well, doctor. My question is hazy is a change, right?
Yes, and I'm explaining to you why it's hazy.
And there is no reference in that report, either by way of impression, diagnosis, or even suspicion of pneumonia. Was there?
That's correct, because the radiologist can't look at the slides at the lungs microscopically like a pathologist can.
Pneumonia is a disease or illness of the lungs, right?
Yes,
Okay, and could be either viral or bacterial, as you've shared, right?
yes,
And it's going to cause symptoms, won't it?
yes,
And those can include. I'm just going to throw them out here. Disagree with me if you need to. Difficulty breathing, right?
I can, yes,
Coughing,
yes,
appearance of kind of an upper respiratory system illness like runny nose,
it might,
sneezing, maybe, fever.
they might have a fever, they might not.
Okay. Now, you're familiar, doctor, with the history provided by the family of Ariana, right?
Yes,
Particularly concerning her appearance and her appearance of well-being in the days before January 20th, right?
yes, including a period where she stopped breathing, yes.
Good point. Where's that appear in your report?
It doesn't, but it's
Didn't
part of
think
the,
so.
it's part of the medical record.
But if it was significant to you, I'm guessing you'd have put it in your report.
In retrospect, it is important.
Doctor, the parents of, or the grandparents of little Ariana reported that she appeared to be just fine the day before. You have any reason to disagree with that?
No,
And the mother said the same thing as to the morning of January 20th, 2018. Have any reason to disagree with that?
no,
And in fact, the defendant described her condition when he laid her down for a nap, as he said, that she was perfectly normal. Have any reason to disagree with that?
no.
I'm going to refer you now, doctor, to a different portion of the records from Cardinal Glennon Hospital, having to do with the infectious disease consult. Okay? You're familiar with Cardinal Glennon, right?
Yes,
It's a children's hospital. It is I don't know what the trauma level would be, but it is a facility where they bring children from some distances because of the resources they have there. Fair?
yes,
They've got teams of doctors who bring their skills to bear in trying to help little kids. Fair?
yes,
Emergency medicine, right?
yes,
Radiology,
yes,
infectious diseases,
yes,
neurology,
yes,
trauma.
yes,
And this was an infant, as you have described, who was in distress, right?
on arrival at Blessing, yes,
Literally at death's door, wasn't she?
her prognosis wasn't good, seemingly.
In fact, it never other than getting a pulse after about an hour of CPR, her condition never changed, did it?
In what way?
Movement, breathing on her own, responsiveness, any of those things. Never changed, did it?
No.
She was lifeless and remained so, correct?
Yes.
Eyes fixed and pupils fixed and dilated?
Yes.
Not a good sign, is it?
No.
And bringing those resources to bear, they brought a number of specialties in to evaluate Ariana, didn't they?
Yes.
And among those was infectious disease, right? Infectious disease specialists, right?
Yes.
They wanted to know if that was her problem or what explained her collapse, right?
I don't remember what the consult was for, but that sounds about right.
All right. I'm going to read to you from the infectious disease consult, I believe on the January 21 pediatric care progress note. That had been a day after Ariana was brought there. And I will read it to you. Cultures. PCR being, I assume, polymerase chain reaction.
Yes.
PCR for virus is negative. Blood and urine and tracheal aspirates sent. Okay? Antibiotics. Prophylaxis, clindamycin and cefta, I think it's Rocephin is the trade name.
I'm sorry, could you repeat that?
Rocephin, R-O-C-E-P-H-I-N.
Thank you.
Started for potential aspiration and strep pneumo superinfection in the face of prolonged unresponsiveness and inability to protect the airway. Let's see if we can't break that down a bit. If I understand that correctly, doctor, what they were doing is giving her antibiotics to prevent the introduction of material, potentially infectious, into her lungs because she had no gag reflex, she couldn't protect her lungs, right?
They gave her 2 different antibiotics because, as the infectious disease doctor described, he was concerned about strep pneumonia. That's the strep pneumo that you sort of jumped over.
Doctor, you would agree with me that when you give an infant who's presented to a hospital like Blessing in as severe a condition as she was in, without any explanation of what caused it, the standard protocol is to administer antibiotics just in case, right?
That's true.
They go on, the infectious disease people go on to say the following. Assessment. No clear infectious etiology or cause as a cause for this infant's decompensation. Have any reason to believe I read that wrong?
No.
Again, I can share that with you if you want to look at it for any reason. All right?
Thank you.
There are references in the other parts of the Cardinal Glennon records regarding assessment of potential infectious problems that I want to just mention to you or read to you. Specifically urine cultures that I'm going to represent to you appear in a report of pediatric critical care progress note of January 21st, and the reference says the following: culture, urine, and gram stain. Collection time, January 20, 2018, 7:59 p.m. Result, gram stain, no organisms seen. Have any reason to believe I read that wrong?
No.
All right. Finally, with regard to cultures and the interpretation of them, a day later, on January 22nd, under the infectious disease consult, it says the following: blood culture pending. Plan, will remove tubes, devices, lines when feasible. Got I can't even pronounce it. Ceftriaxone will continue. Blood and urine cultures pending, but both obtained after 1 dose of Rocephin. Let's talk about that for a moment. When you administer antibiotics, even in an infant like this, just in case, prophylactically, your plan, your hope is to prevent the growth of any organisms responsive to that antibiotic, right?
Yes.
And if that antibiotic works, you're not going to grow out any bacteria if they're responsive to that antibiotic, are you?
That's possible if you have 1 dose.
That seems and appears to be kind of a cautionary note from infectious disease about whether or not any blood cultures are going to be meaningful. Right?
That's correct.
Let's go to a different subject. Sepsis. We'll start at blessing. There is no reference in the blessing records and any impression to a diagnosis of sepsis, was there?
No.
Or an impression of sepsis, was there?
No.
Or consistent with sepsis, suspicious for sepsis. No findings of that kind, were there?
I wouldn't say no findings, no statements, but
No
the
statement.
laboratory tests and other vital signs were supportive of sepsis.
Whatever those findings were, they were not sufficient to rise to a level to cause an entry in the medical records, were they?
I would offer that it also may not have crossed their mind, that their focus was elsewhere.
Well, if that's the case, why then would they have administered antibiotics prophylactically?
I'm not sure I follow that.
Well, let me restate. Bottom line is, there's no reference of any diagnosis or even suspicion of sepsis at blessing. Right?
That's correct.
Let's go to Cardinal Glennon. Having looked through the records at Cardinal Glennon, there is no reference, despite all of the specialties that were involved, all of the resources brought to bear, of any diagnosis of sepsis. Was there?
No, but there was documentation in the medical records of criteria that met sepsis. It's just that they didn't go through the process of looking at it.
At Cardinal Glennon,
That's correct.
no impression of sepsis, no suspicion of sepsis, nothing in their judgment consistent with sepsis.
But
correct?
they were certainly treating it by giving her dopamine to keep her blood pressure up. They were treating it by giving her antibiotics. And they were treating it by putting her...
Blood pressure can drop as a result of a lot of things, can't it, doctor?
That's correct, but with sepsis, it's looking at a multitude of factors, not just blood pressure.
Again, whatever that combination of information that comes back to them, it wasn't sufficient to even raise a suspicion of sepsis as recorded in the medical records, was there?
That's your interpretation of it. It doesn't mean it wasn't sufficient. It did not... they did not consider that in their evaluation of her.
Did you talk to them?
No, it's not in the record.
That's my point.
Mine
It's
too.
just not in the record as even a suspicion, right?
It was a misdiagnosis.
Well, now, that's your conclusion?
Yes,
I don't suppose that statement appears in your report, does it?
I describe the findings of sepsis in my report.
Doctor, the next subject I want to cover.
Okay, let me, Mr. Barnard, let me interrupt just a second. I'm going to give the jury an opportunity to stand up and stretch. The testimony has been long. And I want to also take this opportunity to warn the gallery. There will be no reactions, no statements made in the gallery that might in any way interfere with what's happening here in the courtroom. If it happens, I'm authorizing the bailiff to take action to remove any person who is talking or showing a physical gesture or reaction to anything that's being said. That's just a warning. And at this time, we can all sit down and we'll continue. You may go ahead, Mr. Barnard.
Doctor, I want to move on to another aspect of your report in comparison to the record, specifically the Cardinal Glenn. Okay?
Okay.
You've referred to a condition called DIC. Diffuse? Disseminated.
I'll help you. Disseminated intravascular coagulation.
All right. And would that fit under the general heading of coagulopathy?
Yes.
Okay. Let's talk about that. I think that, if I recall correctly, when Ariana was first worked up at Cardinal Glennon, she received treatment for a clotting problem, either too much or not enough. You recall that?
Yes, she was treated for the DIC, the coagulopathy.
The term DIC does not appear anywhere in the Cardinal Glennon records as a diagnosis or even an impression, does it?
Coagulopathy is used interchangeably with DIC.
My question was, does the term DIC appear in the Cardinal Glennon medical records?
I don't know, but the diagnosis and treatment are there. Diagnosis of coagulopathy and treatment of coagulopathy.
I'm going to refer to, and again, if you want to take a look at this, that's fine. It's a pediatric death summary of Ariana, in which they review the hospital course for this infant. And I'm going to read to you. CT of the abdomen and pelvis was obtained per trauma surgery recommendation due to slightly elevation in LFTs. LFTs, what are those?
liver function tests. Those are the enzymes that the liver released because of the low blood
Thank you.
pressure.
LFTs and mild hypocoagulable state. Ariana was given medication to deal with that while she was there, wasn't she?
Yes, her coagulopathy worsened, and they gave her blood products to help her clot her blood.
In fact, that report goes on to say Ariana received FFP and PRBC, which I assume are those blood products you're talking about?
The FFP is fresh frozen plasma to give her clotting factors, and the PRBC is packed red blood cells because she had anemia.
She was given those products soon after admission for hypocoagulable state, meaning she wasn't clotting enough, hypocoagulable,
Yes,
right? And anemia, respectively. Did you happen to look at the later reports from Cardinal Glennon, particularly the hematological system, in terms of whether or not that worked?
I do recall that one of her coag studies improved. I think one study, the PT, the prothrombin, was abnormal, and then in another study, I think it was the prior study, both the PT and the PTT and the INR were abnormal.
I'm going to read it to you.
Okay.
All right. Hematological system. Red blood count. Counts adequate. Platelets. Counts adequate. Coagulation. No active issue. Treatment. None. Assessment. Coagulopathy has been corrected. Any reason to believe I read that wrong?
No, she had a coagulopathy and they treated it.
CSVT, cerebrosynovenous thrombosis. No mention of that diagnosis or even impression at Blessing, right?
That's correct. She didn't have a CT scan of her head there.
She did, though, at Cardinal Glennon, right?
She had one without contrast, which is insufficient to make that diagnosis.
And there appears no reference from any study taken in isolation or in conjunction with all of the data received from Cardinal Glennon's resources that she had a condition of CSVT, was there?
No, because they didn't investigate it.
Well, there are reasons why, or perhaps a lot of reasons why one might not investigate a particular situation, including, as you've shared, they missed it, right?
Yes.
And another might well be that the information was not sufficient to warrant even suspicion. Fair?
No, that's not fair. With D dimers elevated and a Glasgow coma score of 3 would be good indications, plus the radiologist describing blood products.
And so what you're saying to us is that the entire assembled, specialized, trained staff all together could not and did not see what you did.
I am not manufacturing a blood clot in the skull cavity that has laminations from being in a blood vessel, and it's days old.
Doctor, and I apologize, but that sounds like an explanation, not an answer. The fact of the matter is, what you're saying is all of those assembled resources didn't pick up what you Now say you saw.
Well, unfortunately, that is often the case with strokes in babies, that you have to have a high level of suspicion, which they did not have a high level of suspicion, and they should have.
Let's talk about her, again, just for a moment, her health history, all right?
Yes.
Up until the time she presented the blessing. You described her collapse as a progressive illness, right?
In the hospital, yes.
In the hospital, or, let me back up and I'll ask this question. You have shared with us several times now that this clotting process began before January 20th and continued to cascade or progress in a way that caused all these other things, right?
That's correct.
And that included pneumonia.
Yes.
And that is in the face of all of this observable information from the family and the mother and even the defendant that there were no signs or symptoms in the slightest of pneumonia. Symptoms like coughing or congestion, difficulty breathing, any of that, fever.
I would consider stopping breathing difficulty breathing.
Well, and I apologize if I seem like I'm beating a dead horse, but if that was so significant to you in your discussion of this, seems like that ought to be in your report.
Okay.
Your Honor, I have quite a bit to go, and I just want to alert the court to that, given the hour.
Okay. Can I see counsel in a sidebar? Just- Okay, ladies and gentlemen of the jury, and this includes you, Dr. Turner. Counsel's indicated he has more questions. The hour's getting late. We can continue tonight and finish. I'm at least going to give the jury a break. If doctor, you have limited availability, especially that you cannot come back in the morning and finish, then I would prefer to finish it tonight. Probably going to be another hour at least. Ladies and gentlemen, would you prefer to finish tonight? And while your minds are on the topic, prefer to finish tonight? I see some nods. I see all indicating yes. So I think what we will do at this point in time is we're going to take a 15-minute break, allow you to go get some refreshment, use the restrooms, and stretch. And then we'll be back at 4:45, and we'll continue at this time. So the jury, I remind you of the admonition not to communicate among yourselves, not to communicate with anyone else via any means of your impressions of the case. You cannot do research on your phones or via Google, Wikipedia, any type of source like that. And you're not to allow others to communicate with you. So with those admonitions, you're free to leave the courtroom. Please be back in the jury room, ready to come back into the courtroom at 4:45. Dr. Turner, you're also free to leave the courtroom. I would remind you of the admonition not to speak to either counsel about your testimony.
Yes, sir.
With that, you're free to leave. And please be back in the chair at 4:45. Thank you. The last word, ladies and gentlemen, all assembled. I know the hour is late. I know, the emotions are running high. But I do need your cooperation to not speak, not react physically or verbally to anything that's being said or done. And if you cannot abide by that, I do need you to leave the courtroom now, or don't come back. But if there are any reactions, it's getting late, as I said. I know the emotions are high, but I do need your cooperation not to have any verbal or physical reaction that might detract from what's happening in the courtroom. So with that warning, the court will be in recess until 4:45. Dr. Turner is still on the stand. I would just remind you, Doctor, you're still under oath.
Thank you.
And with that, Mr. Barnard, you may continue with your cross-examination.
Thank you, Ronald. Doctor, I want to discuss with you that part of your report having to do with the heading in your report is called presentation. I take it to mean basically the history provided by those around Ariana at the time she was found unresponsive. History, basically.
Yes.
Specifically, I want to read it, okay? Under the heading of presentation, it says, Mr. Travis Wiley was at the home of Ms. Christina Dunford, mother of Ariana Hoffman, on January 20, 2018, with Ariana Hoffman while Ms. Dunford was at work. Mr. Wiley placed Ariana in a bassinet, Fisher-Price rock and play, in the living room for a nap on or around 1:30 p.m. That was the history you were given, right?
Yes.
He laid down on the sofa nearby and also took a nap. He woke up around 45 minutes or an hour later to find that Ariana's lips were blue and she was not breathing. Mr. Wiley made contact with Ms. Dunford, who called 911. Police and emergency medical services arrived at 2:48. Ariana was transported to the hospital, then transferred by airlift to Cardinal Glennon Hospital later that day. Now, the history given by witnesses or caregivers is certainly as important to, or at least potentially important to a pathologist as it is to a treating physician. Fair?
Yes.
And I want to focus, Dr. Turner, on that part of what I just read having to do with what the defendant said. Said he laid down on the sofa nearby and took a nap, woke up around 45 minutes or an hour later, find that Ariana's lips were blue and she was not breathing. And the time he laid down, according to him, was 1:30. Now, in another part of your report, you note that you had reviewed the following materials in this case: Quincy Police Department reports. Right?
Yes.
You are aware, Dr. Turner, are you not, that despite the fact that the defendant claims he took a nap for 45 minutes or an hour, there was outgoing activity on his phone from that period of time from 1:30 to 2:30 p.m., right?
Yes,
That would be inconsistent with what he shared by way of history unless that phone was doing it all by itself, right?
correct.
Because we know, Dr. Turner, according to the defendant, he was alone with Ariana, right?
Yes,
You did not note that inconsistency in your report, did you?
no,
And you are aware, are you not, that when a person gives a history that is inconsistent with known facts, that can be of concern in terms of whether or not that person was being accurate when they say, or he said he took a nap, right?
that's not my role as a pathologist to determine if he was accurate or not.
And I get that part, doctor, but the fact of the matter is, if the facts show one thing and he claims another thing, that raises, or has got to raise your level of concern or suspicion, doesn't it?
No,
It doesn't?
no.
And I take it then from what you said, if that person is known to have said in response to a question about why his phone was being used, and his response was, phones do things all by themselves all the time, that wouldn't raise any index of concern or suspicion to you in terms of maybe this history isn't accurate?
Again, that's not my role to be a lie detector test for an individual.
Fair enough, but it would seem that you would at least note that in your report because, and I'll go on before you answer the question, because when a person talks about something as significant as the last hour of an infant's normal life, inconsistent stories can be concerning.
It depends on the specifics and the circumstances and what Mr. Wiley defines as a nap. Was he just lying down with his phone and using his phone, or was he actually sleeping? Who's to say?
Right, but what he did say was he was taking a nap and was asleep, right? He didn't say, well, I was laying there, but I was awake.
I understood him to say he took a nap.
In your role as a pathologist, you have referred to the fact that you worked with the City of St. Louis Medical Examiner for a number of years, correct?
Yes,
And part of your job was to render opinions on cause and manner of death, correct?
yes,
Including infants who died for reasons either initially unknown or perhaps suspicious, right?
yes,
And history as provided by a caregiver can be part of that diagnostic picture that you form, right?
So the history of the patient is important.
No argument there, none. But I'm suggesting to you that the history, particularly one that is inconsistent with known facts at a critical time, within a couple of feet of an infant who died, can be of concern, right?
It can be for some circumstances. In this case, I'd already reviewed the autopsy materials by the time I wrote this report.
and yet you didn't even mention that inconsistency, right?
That's correct, because even if he was using his phone, it was still consistent with Ariana having had that blood clot form in her head days before.
And the timeline of your investigation was you did your work and you had already made up your mind based on what you saw.
No, sir.
Well, you can't say you didn't make up your mind if, in fact, you didn't pay any attention to that stuff.
No, I reviewed the materials and then made conclusions based on that review. I didn't already make up my mind at the onset.
Okay. Well, let's just take the statement in isolation. Does it strike you even at just a little bit odd that there's evidence that this person was within 2 feet of this infant for the period of time he was claiming he was sleeping, when the evidence independent of that shows he was awake and on his phone? Doesn't strike you even a little bit funny?
It has nothing to do with my pathologic analysis.
Well, it is well known, is it not, Doctor, that an evolutionary explanation by a caregiver can be very significant to even a pathologist in forming their diagnostic picture.
Oh, so you're talking about cognitive bias?
No, I'm talking about an evolutionary history. I'm talking about this, a history where the caregiver says one thing and either the evidence shows or they say, well, maybe not that. Your index of suspicion does not elevate?
It's something to pay attention to, but in the end, it wasn't relevant to the fact that Ariana had these blood clots forming in her head already.
The opinion of the autopsy physician, the findings of the autopsy physicians, was that Ariana met her death as a result of abusive head trauma under circumstances where the last and only person with her during the last 4 years of her functional life was a defendant. You know that.
Yes, I'm aware of that opinion.
And their findings were that the injuries shown and documented in their autopsy protocol, their autopsy report, were such that they concluded within a reasonable degree of medical certainty that she died of abusive head trauma. You're aware of that, right?
Yes.
When you were working at the St. Louis City Medical Examiner's Office, fact is that you saw and performed autopsies on children who were suspected to be the victims of abusive head trauma or closed head injury, right?
Yes.
And the manner of death was homicide, as you concluded, right?
Yes.
And you made that conclusion in your experience while you were there somewhere between 24 and 36 times, 2 to 3 dozen times, right?
I don't know the numbers. That seems high.
Well, you've been asked that question before. And so hopefully we can avoid diving into that issue any deeper. Would you have any reason to disagree with me that you acknowledge that you made that conclusion of closed head injury, manner of death of a child under 5, somewhere between 2 and 3 dozen times?
That's possible.
Okay. We're going to come back to that in a few minutes. The report that was issued in this case was on the letterhead of Virchow Consulting Services, right?
Yes,
That's a business, right?
yes,
And you are the owner of that business.
I am.
And the nature of that business is medical legal consulting, right?
Medical legal consulting, private autopsies, and contract work as a forensic pathologist.
It includes medical legal consulting.
Yes,
And as part of that, you have been retained by defendants in criminal cases, have you not?
yes, and by prosecutors in criminal cases as well.
Well, let me ask you about that. And let's be specific to this kind of injury, closed head injury, manner of death, homicide. When you were in the medical examiner's office, you shared with us that you came to that conclusion somewhere between 2,000 and 3,000 times over the years you served there, right?
Yes,
Fact of the matter is that since you started your business, you have not come to that conclusion once in the case of a child, have you?
I started that business in 2007.
That's not my question.
Well, that's my answer. I have since 2007, working as a medical examiner for the city of St. Louis.
What I'm saying to you, and my question is, since you left the medical examiner's office, let's put it that way, okay? And maybe I didn't ask the question as I should have. Since you left the medical examiner's office, you have not come to that conclusion once in your work as the owner of that business, which is Virchow Consulting, right?
I know I reviewed a case for an Illinois public defender where I came to the conclusion that it was abuse. And so it didn't go any further than that.
Doctor? Let's deal with that. When do you claim that occurred? That opinion that you gave for a medical examiner?
It was in the past 12 to 18 months. The case was People of Illinois versus Stewart. And I know that because I was going through my files and yesterday and came across that and pulled it because my opinion did not help the defendant.
And when would you have issued that report?
I was not asked to write a report
When
because
did you come to that opinion?
I reviewed that case somewhere 12 to 18 months ago.
You didn't issue a report.
I was not asked to write a report. That's correct.
Fact is, however, doctor, in your consulting business, somewhere between 4 and 6 times, when asked to express an opinion as to the cause of death and unexplained death of a child under 5 years old, you have expressed the opinion that death was by natural causes, right?
Yes.
Now, you are retained by defendants in criminal cases, aren't you?
Yes.
Consulting service is, right?
Yes.
And of course, one of those cases is this one, isn't it?
It is.
Again, we'll come back to that. But first, I want to ask you some questions about medical literature. You know what a consensus statement is?
I know that the American Academy of Pediatrics has what they call consensus statements.
Well, are you aware specifically, doctor, of a medical periodical study, whatever you want to refer to it as, entitled Consensus Statement on Abusive Head Trauma in Infants and Young Children. You aware of that consensus statement?
I'm aware that something like that exists.
And I'm going to read from that, and I'll ask you whether or not you agree or disagree with the statement. Fair enough?
Yes.
In that document, it states, and I quote, professional medical societies use consensus statements to communicate general physician acceptance on a particular topic. These statements are vetted by the membership and designed to help physicians. Agree or disagree with that representation?
I agree that is the intent of the consensus statements.
And in this particular consensus statement, it is, and I quote, supported by the Society of Pediatric Radiology, the European Society of Pediatric Radiology, the American Society of Pediatric Neuroradiology, the American Academy of Pediatrics, European Society of Neuroradiology, American Professional Society on Abuse of Children, and several others. And that it builds on 15 major national and international professional medical societies and organizations' consensus statements confirming the validity of abusive head trauma diagnosis. You have any reason to disagree with that conclusion or representation?
No, but I note that there's nothing about forensic pathologists or the American Academy of Forensic Sciences in that list.
And I was kind of thinking that might be your thought, but here's my follow-up question. Pediatricians, neurologists, neuroradiologists, all deal with this, I don't know what I want to call this, diagnosis. Except the only difference is they deal with it on children who are alive, right?
Correct.
Okay. You deal with it in terms of assessment and diagnosis of children who are not alive, right?
That's correct. That's what
But-
pathologists do.
Right. But the point I'm making here is both of your disciplines, pediatricians and radiologists and the like, on one end, you on the other end, are both dealing with diagnosis and, in their case, treatment, in your case, cause of death of children who are suspected to be victims of child abuse, right?
Yes.
Tell me whether or not you agree with the following that comes from this consensus statement. Abusive head trauma is a scientifically non-controversial medical diagnosis broadly recognized and managed throughout the world. Agree or disagree?
I disagree.
When diagnosed, it signifies the accidental and disease processes, or it signifies that accidental and disease processes cannot plausibly explain the etiology or cause of the infant or child's injuries. Agree or disagree?
I agree.
I think I know the answer to the next question, but I'm going to ask it anyway. The consensus statement goes on to state as follows. There is no reliable medical evidence that the following processes are precise mimics of or causative in the constellation of injuries characteristic of abusive head trauma. And included among those are cerebral sinovenous thrombosis. Agree or disagree?
Well, I disagree with that because you have pathologic evidence. I suppose they are leaving out the pathology because there aren't any pathologists on their consensus statement.
You suppose.
I am showing you today that there was a cerebral sinovenous thrombosis.
Not my question, doctor. You suppose that's why they come to that conclusion because they intentionally left it out. Right? Is that what you're saying?
I'm saying that they're not including CSVT for whatever reason, but they are not including pathologists who make that diagnosis.
The consensus statement goes on to say, that shaking, that the defense position, in cases like we are here now, shaking an infant cannot cause serious injury. Right?
I'm not saying it cannot. I'm saying that doesn't apply to this case.
You do feel, however, though, that acceleration, deceleration injuries to an infant as a result of shaking is just a theory.
It is in the sense that it has not been demonstrated in animal models.
Despite what the consensus statement states, that it is a scientifically non-controversial medical diagnosis.
It is controversial. The reason that I say that is the National Association of Medical Examiners once did have a position paper on abusive head trauma, and they no longer endorse that since 2006 because it is controversial.
The statement, consensus statement goes on to say the medical literature, overwhelming clinical experience and judgment demonstrates that abusive head trauma can be caused by shaking alone.
The medical literature does not show that shaking alone can cause injury to the child. If you look at the references, see if they list any of them that confirm scientific studies on animal models that demonstrate that. All you have in those citations are references to papers that child abuse pediatricians have published in which there is circular logic.
So every one of those organizations, those professional specialty organizations, every one of the physicians who review that information, all taken together, building on other studies, all got it wrong.
I think they're misrepresenting the facts.
The statement then goes into, the consent statement then goes into some of the specific markers or symptoms of abusive head trauma as a result of acceleration, deceleration injuries. I want to read them to you and ask you if you agree or disagree. Okay?
Okay?
Intracranial bleeding is common in abusive head trauma and presents as subdural hematoma.
Yes, if you have injuries unlike Ariana had, so injuries to the neck, bruises on the arms and chest, skull fracture, and that wasn't the case here.
Injuries to the neck. What kind of injuries are you talking about?
Whiplash injuries. So acceleration, deceleration requires whiplash injury to the neck with hemorrhages of the muscles, tears in the ligaments, sometimes dislocation of the vertebrae.
In fact, you were of the belief, are you not, doctor, that in absence of cervical injuries, ligamentous injuries, that you cannot diagnose abusive head trauma from an acceleration, deceleration injury, right?
That's correct.
The consensus statement on that subject goes on to say the following. prior to the knowledge of the ligamentous injury to the neck, those who denied the existence of shaken baby mechanism used lack of spinal injury to boost their unfounded theory. However, it is important to emphasize that absence of ligamentous injury does not exclude abusive head trauma.
That's not what biomechanical engineers say.
Are you a biomechanical engineer?
No, I am not.
Doctor, let's talk about retinal hemorrhages in this setting, okay? You've talked about it a little bit. I'm going to read from the statement. The incident of retinal hemorrhage in abusive head trauma is approximately 85%. Hemorrhages that are too numerous to count, multi-layered, and extending to the ora serrata are specific. I take it you disagree with that.
I do. My colleague, Dr. Pat Lance, has studied retinal hemorrhages extensively and has identified diffuse and multi-layered retinal hemorrhages in children who've died of drowning, children who have died of infections, etc.
The statement goes on to say there is no evidence in the literature, where primary CSVT thrombosis has been identified as the cause of acute subdural hematoma or a presentation with abrupt collapse with prolonged coma in a previously healthy child. I take it you disagree.
I do. In fact, there were 2 reports of children with COVID who developed CSVT and subdural hemorrhage.
2 reports, 2 cases.
2 cases, and adults as well, and subdural hemorrhages have been documented with CSVT in adults. I list them here. 2018, Rulan, Hauser, 1996, Kunle Hassan, 2018. Let's see.
A grand total of 2 cases.
Of COVID, but prior to that, there have been other neurologists have published papers. The American Society, the American Stroke Association has published papers on subdural hemorrhages occurring with CSVT strokes in children.
You used to be of the opinion, did you not, that acceleration, deceleration injuries from shaking an infant can cause abusive head trauma, including subdural hematoma, subarachnoid hematoma, extensive and multi-layered retinal hemorrhage, correct?
That is how I was trained and what I was taught. And then over the years, my experience has caused me to question whether that really is the case.
And I think you've described it in the past as you decided to study it on your own, right?
I've had cases that I have gone to the trouble of reading research papers and other published articles on the topics.
One more that I wanted to discuss with you, Doctor, if I may. The statement, consensus statement, states that the 2 most common histories provided in cases of confirmed abusive head trauma are low height fall of less than 4 feet. The other most common history is one where the person says there was no trauma at all, no history of trauma. You aware of that statement? And do you agree with it or disagree with it?
Could you repeat that, please?
Sure. The 2 most common histories provided in cases of confirmed abusive head trauma are a low height fall of less than 4 feet, 4 to 6 feet, and no specific history of trauma.
I don't know. I don't know what they mean by confirmed.
Well, how about the part of it where there's no history of trauma, but all of the imaging studies, the autopsy information indicate that it was in fact abusive head trauma?
Again, in a case like this where abusive head trauma was the conclusion of the pathologist, there was no history of trauma. And yet we see this blood clot in the head that formed days before January 20th. So it's entirely consistent that an innocent person could say that there was no trauma, there was no fall, or otherwise.
And it's also entirely consistent that a person who says there was no trauma ain't telling the truth. Right?
That's correct.
Doctor, the statement also adds the following, that in some legal abuse of head trauma cases, it is argued on behalf of defendants, frequently supported by opinion testimony provided by a small group of medical witnesses, have offered a scientific sounding critique of abusive head trauma. Are you among those?
I am here as an independent reviewer
Bless you.
to describe the pathologic changes that were present that are unrelated to injury.
Independent reviewer.
Yes,
Okay. Let's go. Again, you are retained by the defendant in this case, right?
yes,
That's how you got involved, right?
yes.
Doctor, it is your opinion in this case that Ariana Hoffman had an infection, right?
Yes,
Caused sepsis,
yes,
that caused CSVT, right?
well, the CSVT was exacerbated by the sepsis and infection.
And that caused Ariana to have a stroke,
Yes,
from which she died.
yes,
And that she also had DIC, which complicated that scenario, right?
yes,
Now this is not the first time you have expressed that precise diagnosis in a case where a person has been charged with abusive head trauma resulting in the death of a child in a criminal case, is it?
no, that's correct.
In fact, in one of those cases, the infant was treated right here in Quincy at Blessing Hospital, right?
I don't recall.
Taylor Keys,
I don't
Marcus
recall.
Mays, ringing a bell?
Oh, yes,
Within the last year, in the state of Maine, you have expressed an opinion on behalf of a defendant in a criminal case where the defendant was accused of abusive head trauma causing the death of a child where that child presented unresponsive to a hospital. The allegation being that it was a result of shaking that child. And you concluded on behalf of that defendant that the infant had an infection, in that case COVID. Remember that?
yes,
That caused sepsis, right?
yes,
That led to CSVT
yes,
and a stroke
Yes,
as a result of which the infant died. Right?
that's correct.
And you billed for that, didn't you?
Yes, I do. I expect to be paid for the work I do.
And you billed for the representation or opinion you shared on behalf of Marcus Mays, didn't you?
I billed for the work that I did.
The consulting service did, right?
Yes,
And in fact, in the case of Marcus Mays, that bill was for $22,487, wasn't it?
I trust you looked that up.
I did.
Okay.
And in fact, that number did not even include your time testifying in trial in that criminal case on behalf of Marcus Mays, did it?
I don't know.
Now, I guess it stands to reason and logic that the more you are retained, the more Virchow Consulting receives an income, right?
I do a variety of cases, pro bono and indigent cases.
And I appreciate that, doctor, but that is not my question. The more reports you generate, the more money you make, right?
That is not entirely true. So, as in the Illinois versus Stewart case, I reviewed it. It didn't go any further than that.
I'll make it simple. When you issued a report in the case of State of Missouri versus Marcus Mays, you got paid for it, didn't you?
Yes,
And when you showed up in court, you got paid for it, didn't you?
I was paid for the work that I did.
And you charged by the hour, right?
Yes,
I think $350 an hour in people or State v. Mays, right?
yes,
Ended up being about 20 grand plus for your bill, right?
that's correct.
Likewise, in this case, again, you are retained, hired by the defendant, right?
Yes,
And you get paid by the hour, don't you?
I get paid by the state of Illinois, and I do not get paid by the hour. I was given essentially a retainer in this case, a set amount.
Paid by the state of Illinois, right?
Yes,
And your meter's running right now, isn't it?
no, I signed a contract, or there was an affidavit or something like that that says I would be paid $5,500 for everything.
Well, Your Honor, I am going to ask the court to take judicial notice of the following orders entered in this case. I'm asking the court to take judicial notice of its own records, specifically that on February 7 in 2020, expert witness funds in the sum of $1,650 be paid to Dr. Jane Turner for this case. I'm asking the court to take judicial notice further of its own records that on April 29, 2020, that expert witness funds in the amount of $5,550 be paid to Dr. Jane Turner for this case. And I'm asking the court to take judicial notice that on April 16, 2021, the court entered an order that expert witness funds in the sum of up to $5,000 be paid to Virchow Consulting. That comes to a total of north of $12,000, doesn't it?
It does. My records, I only had the 5,500. I have not been keeping track of the hours because my understanding was, and maybe I was wrong, but my understanding was I would be paid just that amount and no more, no matter what length of time I spend on the case.
I have no further questions.
Thank you, Mr. Barnard. Mr. Nelson, I'll give you the opportunity to ask redirect questions.
No redirect. Thank you.
All right. Is the doctor released from her subpoenas?
Yes.
Doctor, you are free to go.
Thank you.
Thank you. Okay, the record should reflect that the witness has now exited the courtroom. The door is being closed. Ladies and gentlemen, that concludes our evidence for today. I thank you on behalf of Adams County for staying beyond what was told you at the beginning. The limited availability of this witness, I think, probably necessitated this, but I appreciate your patience. We are going to adjourn for today. It's anticipated that closing arguments will occur sometime tomorrow morning. If there is additional evidence, that'll be heard first in the morning, and then you will get the case. It's anticipated you'll get the case tomorrow, sometime maybe late in the morning. But I'm going to release you for the evening. Before I do, I need to once again admonish you that you're not to do any research whatsoever, via any means whatsoever, about anything you've heard in this case, about any person, about any witness, about any attorney, about any judge in the case. You're not to do any searches on the internet to try to get information about any of the legal concepts or any of the other concepts you've heard in this case. You're to rely solely on the evidence that you hear in this courtroom and on the law that you'll be instructed upon in deciding this case. You're not to discuss the case among yourselves or with anyone else, family, friends, until you get this case and begin your deliberations, which is anticipated to be sometime around midday tomorrow. So with that admonition, I am going to excuse you from the courtroom. I would ask that you be back at 8:45, our usual time, and we'll plan to begin somewhere around 9 o'clock in the morning. So thank you.
All right.
The record should reflect that the jurors have now all exited the courtroom. The door is closed. Counsel remains. Mr. Wiley remains. Let me take just a break just a moment. Nicole, what's your availability? Are you good for another, say, half hour? Are you? Okay. All right. Counsel's still in the courtroom. Mr. Wiley's still in the courtroom. There are a number of things that still need to be done before closing arguments in the morning. Counsel, we do need to finalize the jury instructions. We did a preliminary conference yesterday afternoon. I would say, based upon that preliminary conference, that the jury instructions are relatively few for a case of this nature. The corrections that had to be made were relatively few. Counsel, would you like to? We could do it one of two ways. Counsel, let me say that. we could finalize the jury instruction conference tonight, or we could do it, I suppose, at 8:30 in the morning. Mr. Barnard?
I would prefer the latter if I have a say.
Okay,
I would as well, Your Honor.
okay. Well,
I don't think it would take us very long.
I don't think it's going to take long either. So I think that doing it that way, the only thing that's going to take a little longer is, as counsel knows, I need to have a conversation with Mr. Wiley. I suppose I could do that part tonight, if you wish.
Yes.
Okay. All right. Mr. Wiley, I need to address you with some questions.
Yes, sir.
All right. Before I do, I want to make sure that you're not under the influence of any type of alcohol, drug, or medication. Is that true?
Just my prescription medication.
All right. Does that prescription medication, what is it, Mr. Wiley?
I take blood pressure medication. I'm not sure which one affects her, and I think that's just about it.
All right.
And that's just in the morning.
All right. Here's my questions about those medications. Do they in any way impair your ability to understand what I'm saying to you?
No, Your Honor.
Do they impair in any way your ability to follow what's going on in the courtroom?
Not at all, Your Honor.
All right. Do they impair in any way your ability to communicate with your counsel, Mr. Nelson?
Not at all.
Do they in any way impair your judgment?
No.
All right. You have been advised in this case. I believe there was a judge before me in this case, and then after my participation in the case, you've been advised, among other rights, that you have the right to remain silent, and that silence cannot be used against you. Have you not?
Yes.
All right. Well, in any case, I'm advising you now.
Oh, okay.
And I want you to understand that one of your rights as a defendant is the right to remain silent, and that silence cannot be used against you. Any questions about that?
No, Your Honor.
All right.
Not at this time.
That means at a criminal trial like we're in, you have the right to testify or to not testify in this trial. Do you understand that?
Yes, I do.
That is one of those rights that is considered fundamental and considered a right that you, as a criminal defendant, make in the final analysis. I encouraged you on Monday to discuss those rights with your counsel. But in the end, you're the one that makes it. You understand that?
Yes, Your Honor.
And the decision whether to testify, if you make the decision not to testify, the jury will be instructed, among other instructions, that they cannot consider that fact in determining this case. You understand that?
Yes, Your Honor.
On the other hand, if you make the decision to testify, they will consider your testimony the same way that they would consider any other witness. You understand that?
Yes, Your Honor.
And have you had the opportunity to discuss whether or not you're going to testify in this case with your counsel, Mr. Nelson?
I have.
And are you satisfied with those discussions that you've had?
Yes.
You feel like any question you've had about that has been answered to your satisfaction. Is that correct?
Yes, Your Honor.
Have you come to a decision at this time whether or not you are going to testify?
I will not be testifying, sir.
All right. And Mr. Wiley, I want to make sure that you have not been pressured in any way by anyone, including Mr. Nelson, not to testify. Is that correct?
That is correct. It's solely my decision.
No one's pressured you to make that decision. Is that correct?
Correct.
You're making it of your own free will.
Yes.
And you're making it after having discussed it with your counsel, Mr. Nelson.
Yes, Your Honor.
Do you have any questions of me about that?
I do not. Not at this time.
And you've made the decision to not testify. Is that correct?
Correct.
Okay. Okay. We will then, with that, record having been made, we will continue the jury instruction conference to tomorrow morning at 8:30. Is there anything else either counsel wishes to raise before we adjourn for the evening? Mr. Nelson?
No, Your Honor.
Mr. Barnard?
No, Your Honor.
All right. So we will convene at 8:30 in the morning for a final jury instruction conference. And then, Mr. Nelson, let me ask you, I'll ask you again in the morning. You don't have to make the decision tonight, but do you anticipate calling any other witnesses to testify?
No.
Mr. Barnard, do you anticipate any rebuttal evidence?
I do not.
So then it would be the expectation then that we would conclude the jury instruction conference. Of course, if there are any corrections to be made to jury instructions, we'll have to do that. But then immediately following the jury instruction conference, we will convene and begin closing argument. Is that your understanding and agreement, Mr. Nelson?
Yes.
And Mr. Barnard?
Yes, Your Honor.
Okay. So with that then, the court will be adjourned until 8:30 in the morning.
All rise, please, the session is recorded.